Mm.
Okay, hello everyone. So, okay, I have Anuj Kumar. Am I audible? And everything is okay so that we can start the session. So you can reply here. Let me just check. Okay, good evening. Okay, good evening. Good evening, everyone. So I'm audible and we can start the session. Okay. So let me start with anatomy MCQs. Actually, these MCQs are targeting your revision, and the most important pattern of question will be asked from these topics only. So I want everybody to participate in this anatomy test series, which is the INI CET RDx. So let's start with this. So I'm going to start with the first MCQ. Let me read it for you. So all of you can write your answers in the message box. Okay, dear. Yes. Good evening, everyone. Good evening. So a 32-year-old woman is admitted to the emergency department with a complaint of pain in the anterolateral aspect of thigh. Physical examination is revealed a swollen and a tender right thigh anteriorly. Extension of the knees was limited due to the pain, and ultrasonography of the area revealed a defect in the fibers of quadriceps muscle, confirmed by the CT scan of the limb. Which of the following is the embryological origin of affected structure? So for solving any MCQ, so this is an MCQ which is a clinical MCQ. So I got an answers from Anuj Kumar and Anuj Sarma, absolutely correct. But I want to explain how we are going to approach to the most correct answer. Now there is actually the pain is in the knee and there is defect in the fibers of which muscle? Quadriceps muscle. Which muscle? Quadriceps muscle. So embryological origin of the affected structure. So this clinical question is targeting about the muscles of the lower limb. Quadriceps femoris is the muscle in the anterior aspect of the thigh. It's a group of muscle which is having, if I am using the word, if the word that is used quadriceps, it means what? What does this word quadriceps mean? It means it's containing vastus medialis, vastus lateralis, vastus intermedius, and rectus femoris. So this is quadriceps femoris muscle on the anterior aspect of thigh, and we have to know the embryological origin of the affected structures. Four options are there. So when I am going to solve, I will explain the correct answer and I will also explain why the other options are not correct. So as both of you, Anuj Kumar Chaudhary and Anuj Sarma, is absolutely correct. So I would like to give a thumbs up for them. And the reason is that the muscle is originating from the migration of cells of para-axial mesoderm. Let's have a detail of this because this has been asked several times. So let me tell you the details of this. So when I am, so basically when we are talking about this, quadriceps femoris group of muscle, actually this is the muscle of lower limb which is developing from myotome. It is developing from myotome of the somites. So what is somites? So embryologically, when you must have attended the session of general embryology and you must have come across the word somite. So whenever the word somite is used, what does that mean? So actually somite is a block-like structures formed from somatomeres, and somite is formed from the condensation of para-axial mesoderm. So this is very important, which is giving us the right answer for this MCQ, that the para-axial mesoderm condense to form somites, and which will after that form a trilaminar disc. After the formation of trilaminar disc, there is formation of para-axial mesoderm, which will further form the somites. Now, coming to the general details and how it is formed, they first appear, when I am talking about the somites, they appear as a segmental block, which is called as somatomeres. What is it called as, my dear students? It is called as somatomeres. And along the central axis of the embryo, the cells after that undergo the process of epithelialization. Actually, somite is again consists of various components. It is further divided or differentiated into sclerotome. Okay, it is differentiated into sclerotome. It is differentiated into dermatome and myotome. So further, somite is differentiating into three forms: sclerotome, dermatome, and myotome. Okay. So sclerotome is the ventral portion of it. The dorsal portion has got the dermatomes in the central and myotome in the lateral aspect. The cells in the myotome part of the somites will proliferate and will be migrating within the dermatome to form will form dermomyotome. Now, eventually what happens, the cells in the somite will lose its connection with that and they become mesenchymal in origin. Actually, the sclerotome cells will lead to the formation of vertebrae and the ribs, and the answer is myotomes. The myotomes will form the skeleton muscles, and quadriceps group of muscle is involved in this case. So the correct answer will be paraaxial mesoderm, which is forming somite. And if you want more precise answer, then we will go with the myotome portion. Dermatome will form dermis of the back. Now, I would also like to show you a cross section. So please see this image. In this image, you can see the cross. If you want, I can slightly enlarge this. So just see, this is actually showing the differentiation of somites into an organization of somites and how paraaxial mesoderm is forming somites and forming its intermediate and lateral plate mesoderm. So I'm just enlarging this. Here you can see this is the neural crest and the notochord and the neural tube, and on either side of it, that differentiation occurs and there is formation of the paraaxial mesoderm forms the somites. And also you can see there is the portion which is lying in between the lateral plate and the paraaxial mesoderm. This is called intermediate mesoderm, which is giving rise to urogenital system. So this is how the differentiation takes place. Now, so we have got the right answer, and before proceeding to the next question, I just want to rule out the other options. Why lateral plate mesoderm is not the right answer? Because lateral plate mesoderm is forming the coverings of the organ, serous membrane and the heart. The dorsolateral migration of neural crest is also not right, because we know that neural crest is giving rise to several structures in our body. It is forming many important structures in our body like dorsal root ganglias, leptomeningeus, sympathetic ganglias, the adrenal medulla, the chromaffin cells. Intermediate mesoderm, as I told you, is also not the right answer. The reason is that it will lead to the formation of urogenital system and accessory glands. Okay, Aditya and everyone, Karthik, Anuj, everyone. So let's move on to the next MCQ. So I think everyone is aware with the right answer. And now we will come up with the next MCQ. Okay, all the best to everyone. If anyone is having any doubt, they can ask me right itself when the session is going. So this is an image-based question, and this kind of image-based question has been asked in the previous year of examination. So injury to the marked nerve can lead to. So there is a cadaveric image. If you want, I will enlarge this image for you. The injury to the important structure which is shown here, a red color arrow has been marked on that nerve. You tell me what will be the right answer. The patient will have loss of sensation over hypothenar muscles. The patient will have loss of sensation over dorsum of little finger and loss of sensation on the nail of index finger and loss of sensation on the fourth interdigital cleft. So 4 options are there and you can mark the right answer. Yes, good evening KK, good evening Anuj, good evening Anuj Sharma, Karthik, everyone. Yes. Aditya, so can you tell me the right answer? So one of the student, Anuj Kumar, is telling, yes, Dr. Anuj is telling the right answer is median nerve. So can you tell me the clinical representation which will be seen in the patient? So yes, the hint which I will give you for this session is that this is the region of cubital fossa. Autonomous zone for median nerve. Okay. So yes, good evening, Dr. Munair Guljar. Yes, good evening. Yeah, good evening. So A, B, C, D. So let me show you the image once more. So I'm just enlarging this image. Everyone, I have just enlarged this image. So here what happens, this is a nerve. Okay, I'm using yellow color for the this structure. This is the nerve. And close to it, we have got one artery here. So this is the artery. Okay, and here we have got biceps tendon, and this is bicipital aponeurosis. What is this? This is bicipital aponeurosis. And laterally, one more nerve is there. Now, coming to the correct answers. So first thing which is quite clear by seeing this image, that this is the region of cubital fossa. So here what happens, this is M for medial size and this is L for lateral size. So this is M for medial side and this is for lateral side. So this is the region of cubital fossa. And here actually this structure is very easily understood that this is biceps tendon, and the medial extension of biceps tendon is called as aponeurosis. This is what? This is aponeurosis. Which aponeurosis? This is the biceps aponeurosis. So this is the biceps aponeurosis. And if this is the reason of coming to, if this is the reason of cubital fossa, we know that structures of the cubital fossa as from medial to lateral will be MBBR. What is the mnemonic, my dear students? The structure of the cubital region from medial to lateral will be MBBR. So that means coming to this again image, coming to this image again, that means, okay, let me write the labeling. So that means this structure is median nerve. This will be the brachial artery. This will be the biceps tendon. And this structure which you are seeing is the radial nerve. Okay. So that means from medial to lateral, the medial most structure, this structure is the median nerve. This is the brachial artery. This is biceps tendon, and the lateral most nerve is the radial nerve. Okay. Also in this diagram, we can see this is BR for brachioradialis and this is PT for the pronator teres. Okay. So yes, Anuj. Now, loss of sensation on hypothenar muscle is wrong. Why loss of sensation on hypothenar muscle is wrong? Because hypothenar region, that is medial side. So, if you will see the medial aspect of the palm on the medial side, the medial 1.5 of the palm, both on the palmar aspect and the dorsal aspect is supplied by ulnar nerve. So, yes, absolutely correct. This is for ulnar nerve. So, it is wrong. Loss of sensation on the dorsum of little finger is also for ulnar nerve. Loss of sensation on the nail of index finger is absolutely correct answer. This is the reason which is supplied by the median nerve. Loss of sensation on the fourth interdigital cleft is also wrong. This is corresponding to medial size only. So this is also not the right answer. So I just want everybody to concentrate on this. This is the marked nerve in the image. Is everyone okay? Yes, yes, dear. The loss of sensation of fourth interdigital cleft. Interdigital cleft. Okay, my dear Anu Sarma, if see this image, if it is on the dorsal aspect, if for example 1.5 fingers on the dorsal aspect and that of palmar is all supplied by ulnar nerve. Rest dorsum of the side of the hand is supplied by radial nerve, but medially we have got the medial nerve and also on the nail buds, also the nail buds. So if you will see this diagram, the marked nerve is median nerve. Okay, and here in this diagram, if you will see, this is the median nerve which is giving innervation on the lateral 3.5 of the fingers and the palm. Median nerve is also giving interdigital cleft. Interdigital cleft. Dorsally, if we are talking about dorsally the interdigital cleft, then it is radial nerve. Otherwise, if we are talking exactly the reason of interdigital cleft on the dorsal aspect, it will be radial nerve. And if we are talking about the interdigital cleft on the palmar aspect, then it can be either ulnar nerve or the radial nerve. So here, loss of sensation of fourth interdigital cleft. Which interdigital cleft? Fourth. First, second, third, fourth. So that can go medial aspect. So definitely it's quite clear that some of the options are just given to confuse you. The right answer will be loss of sensation over the index finger. That is absolutely right answer. So Anuj Sarma and everyone, is it okay? Is it okay, everyone? Can we move to the next MCQ? Can we move to the next MCQ?
Recording in progress.
So let's move on to the next one. Okay. Identify the type of cartilage. Identify the type of cartilage. A, elastic cartilage. B, hyaline cartilage, fibrocartilage or articular cartilage. Okay, Anuj Sharma, for the previous question, it is not mentioned dorsum or the palmar aspect. So either radial nerve or ulnar nerve. Definitely medial nerve is, the most correct answer will be index finger for the previous one. Okay, the option given is, we can see an image and we can also see the 4 options of the cartilage: elastic, hyaline, fibro and articular cartilages. So Anuj Sharma, KK, and everybody is telling that it is an elastic cartilage. So basically, if you want, I can enlarge this image and you can see this cartilage. So this is exactly the high power view of the image. And when you see the high power view of the image, what you can appreciate that these are all chondrocytes. These are all chondrocytes. So here what you can see, there are chondrocytes, and if you will see the image nicely, you can see in between the elastic fibers are brightly stained. Few elastic fibers are also running. So it is brightly stained figure which you are seeing. The image is brightly stained. You can see these are very small chondrocytes, and here this will be the part of cut section of perichondrium. So the outer covering of the cartilages in elastic and that of hyaline cartilage is perichondrium. So it is having perichondrium. The outer part is the fibrous pericardium. So this will be the chondrogenic layer. This will be the fibrous layer of the perichondrium. And the whole slide is stuffed with maximum number of chondrocytes. So we can see chondrocytes are stuffed and it is brightly stained and it is having the elastic fibers. So many elastic fibers, branching elastic fibers are running in between. So definitely this is the elastic cartilage. So we have got the right answer, elastic cartilage. Now I will come up with a comparison of all the cartilages, but why not hyaline cartilage? Actually, the students can get, you all can get confused with hyaline cartilage, but generally, whenever hyaline cartilage will be there will be a correct form of cell nest and the elastic fibers will be not there, and basically the slide will have a basophilic appearance. So the slide will have basophilic appearance and also homogeneous arrangement will be there, and maximum number and no elastic fibers will be there. No elastic fibers. No E means no elastic fibers. Yes, Anuj Sharma, same refractive index of the matrix is there. So that is the reason it will be more homogeneous basophilic appearance. Fibrocartilage, there will be no perichondrium. So the perichondrium will not, yes, ground glass appearance was also there. Articular cartilage, generally it is at the level of junction. So generally there will be no perichondrium. Also, there will be no perichondrium, and also there will be a part of bone. A part of bone will be also residing there. So all these things were not there. So definitely we have got the right answer as the elastic cartilage. Absolutely correct. Yes, Anuj Sharma. Now, I just want everybody to see this image where you can see the they can see the comparison of a schematic diagram and that of a HNE stain diagram, where they can have the comparison of 3 types of cartilages. So, can anybody tell me which type of cartilage is present in hyaline? Which type of collagen fibers are present in hyaline and elastic cartilage? Can anybody tell me which type of collagen fibers are present in hyaline and elastic cartilage? So this is very important and I just want everybody to know this. Actually, elastic cartilage will have type 2 collagen fibers, Yes, you are right. Hyaline will also have type 2 collagen fibers, and fibrocartilage will have type 1. Actually, fibrocartilage is present at the junction of joints, and basically it is, the example of fibrocartilage is like pubic symphysis. It is present in acetabular labrum. It is present in glenoid labrum. Elastic cartilage is present where we have got more of elasticity. As you can see in this slide, the whole slide is brightly stained. Many elastic fibers are there. Along with it, the chondrocytes are in maximum number. The number of chondrocytes, as you can see, the whole slide is having a wavy appearance. Large number of collagen fibers are there, and number of the chondrocytes, as you can see, is less. It is scanty. In case of hyaline cartilage, there is group of, you can see, the cartilages are arranged in group, and this group is called as cell nest. So basically, hyaline cartilage is of two varieties. One is articular cartilage and the other variety is costal cartilage at the anterior end of the ribs. Is it okay, everyone? So you have to keep, actually this can come as an image-based question. So you have to keep this differentiating features of all the three cartilages in your mind. Then you will be able to mark the right answer. Okay. So let's move on to the next MCQ. Everyone, let's move on to the next MCQ. I'm checking your messages also. Is it okay? Anuj Kumar Chaudhary, Anuj Sarma, KK. So let's move on to the next one. Identify the arrow marked structure. So actually, this is an image-based question. You have to identify whether it is Golgi, satellite, basket, or Purkinje cells. Whether it is, so please mark the right answer, whether it is the Golgi cells, whether it is the Purkinje cells, stellate cells, or basket cell. If you want, I can give an enlarge up image. So see here, this is the cell which you have to identify. This is the cell which you have to identify. Okay, many of the students, Divya, Osama, Soumya, Manish, Goswami, everyone, Anuj, everyone has given the right answer. This is Purkinje cell. Actually, this is the slide of cerebellum. This is the slide of cerebellum. And the flask-shaped cells, which is seen, which is lying in the single layer, is the Purkinje cell. So actually, the characteristic feature for the identification of the cerebral cortex, actually this is present in the cerebral cortex, which is the Purkinje cells. Actually, when you see the cerebral cortex of the cerebellum from outside to inside, there is a molecular layer, there is superficially there is molecular layer, then we have got the single Purkinje cell layer, and then we have got inner granular cell layer. So the largest in size and visible like a flask, as you can see, having dendrites. As you can see, it is having the dendrites. These are all dendrites which is seen, and this is the Purkinje cells which is flask shaped. So right answer is large flask shaped neurons. Absolutely correct. Now, before proceeding to the next MCQ, I just want everybody to have just a quick revision of Purkinje cells. Actually, Purkinje cell bodies, if you will see, it is flask shaped. It is flask shaped, having thread-like extensions which is called as dendrites. So thread-like extensions are dendrites, and actually it is having one projection which is called as axon. So that one projection is axon, that is controlling the parts of the movements of the brain, the cerebellum. The Purkinje cell is actually a unique type of neuron-specific cell which is present in the middle layer of cerebral cortex, and it is very important. Why? Because they are massive in size and have the ability of integrating large amount of information by remodeling the dendrites. So this is a characteristic feature for identification of cerebellar cortex. Cerebellar cortex. Okay, dear? Yes, Anuj Sarma, absolutely correct. Everyone is absolutely. So I would like to give you a thumbs up and a clap. Very good. Now let's move on to the next one. Before moving to the next, I just want you to show the histological image of the cerebellum cortex. So as I told you, the outermost layer will be the molecular layer. Then we will have the large flask-shaped Purkinje cells. This is the dendrites and this is the axon. So this is the Purkinje cell layer. This is the second layer. And the third, which is you are seeing densely populated, is the granular cell layer. So all the cells, if we talk about the cells which is present in the cerebellum, they are inhibitory except the granular cells, which is excitatory in nature. This is the cerebral cortex where you can see the granular cells are there as the third layer. This is the Purkinje cell layer and this is the molecular, the superficial. If you enlarge it, you can see this flask-shaped cells are the Purkinje cells. These are all Purkinje cells. Okay. So let's move on to the next. Now I would like to solve the next MCQ along with you. Is it okay, everyone? Let's solve the next one. Left recurrent laryngeal nerve is having comparatively longer course due to the persistence of which pharyngeal artery, whether it is the third, whether it is the fourth, whether it is the fifth and the sixth. Okay. Left recurrent laryngeal nerve. If actually there is a difference in the course of right recurrent laryngeal nerve and left recurrent laryngeal nerve. And the reason is persistence of one of the artery. Can you tell me the answer? So yes, I got Soumya, I got Anuj Sharma, Anuj Chaudhary, and I got Manish Goswami. Everyone has given a right answer. Yes, this is the persistence of sixth pharyngeal arch artery. Actually, I would like to show you an image where you can see because of the persistence of the six, generally it obliterates, but on the six, on the left hand side, it persists forming ductus arteriosus, and that is the reason that left recurrent laryngeal nerve has got a longer course. So let me show you this. So left recurrent laryngeal nerve is longer than that of the right because of the persistence of sixth pharyngeal arch artery, and this sixth pharyngeal arch artery will form ductus arteriosus. What it will form? It will form ductus arteriosus. So here you can see this connecting link, which you can see here. This is the connecting link. This part is the ductus arteriosus, which is actually degenerated on the right side, but it remains in the left side. And after in the adults, what happens? Ductus arteriosum will form ligamentum arteriosum. This is forming. So actually, this is forming connection between the pulmonary trunk and that of arch of aorta. So this is arch of aorta, and this is the pulmonary trunk, as you can see here. And this connection is via ductus arteriosus. When in adults, the ductus arteriosus will form ligamentum arteriosum, and that is the reason that the left recurrent laryngeal nerve is having longer course in the left hand side as compared to the right hand side. Yes, yes, Anuj Sharma, you are absolutely correct. You are absolutely correct. Let's move on to the next one. Okay. So take your time and please mark the right answer. Arrange the following cells in the basal to the luminal side. So I'm talking about seminiferous tubules. Okay. So you have to arrange the cells which is involved in the process of spermatogenesis and spermiogenesis, and you have to go from the basal aspect to the lumen aspect. So arrange it. First is spermatogonium, spermatozoa, primary spermatocytes, spermatids, myofibroblasts. Select the correct order A, B, C, D. So please mark the right answer. So here I am getting a few of the students. Most of the students are telling the arrangement of structure as B, and a few students are telling it's D. So basically, actually, you have to go from the basal to the luminal side. You have to go from the basal to the luminal side. So in the luminal side, the most mature form of the sperm will be there, and we know that the other name of sperm is spermatozoa. So that is the hint which is given to you, and now you can give me the right answer. Yes, absolutely right. B is absolutely right answer. Again, a thumbs up goes for you. Actually, this you have to know the steps of the process of spermatogenesis. So the process of formation of spermatids from the primitive germ cells is the process of spermatogenesis, and the transformation of spermatids into mature sperm, that is spermatozoa, is called as spermiogenesis. So we have to know that process, and then we can come on this option. So see here, if we are talking about the process of spermatogenesis, actually, which is taking place in the seminiferous tubules. As you can see, this is this image which I am showing you is showing the cut section of seminiferous tubules. And when I am talking about the basal aspect, it will contain the basically having the primitive cells, that is primordial germ cells, and it will have myofibroblast on the most myofibroblast present on the basal aspect. Then we will have PGCs, the primary germ cells, which will undergo the process of mitosis and will form spermatogonium. The spermatogonium will undergo mitotic division and will form. So as you are proceeding from the basal to the luminal side, it will lead to the formation of primary spermatocytes. The primary spermatocytes will go the process of first meiotic division, which is a reductional division, and this will form the secondary spermatocytes, which will undergo second meiotic division and will form globular spermatids. Actually, the mature form of sperm is like, as you can see, elongated one, that is the mature sperm, which is also called as spermatozoa. And this process is called as spermiogenesis. So you can see from the outside to inside, that is from the basal to the luminal side, this is how the different form of the sperms will be arranged, and the primitive one is spermatogonium and the mature sperm is called as spermatozoa. So that means if we will see this arrangement and I have to give the most correct answer, the most primitive is fifth. So first will be myofibroblast, then we will have spermatogonium. Spermatogonium will be transformed into the primary spermatocytes by the process of mitotic division. Then we will have the secondary spermatocytes, which is exactly not given here. So we will go with spermatids, and the spermatids will finally form the spermatozoa. So that means B will be most correct answer. So B is the most correct answer. Is it okay, everyone? If you have got any doubt, please let me know. So B is the most correct answer. And I just want everybody to see this image where you can see this part is the lumen. Okay, and this is the basal aspect. This is the basal aspect. So we will have the myofibroblasts. We will have the spermatogonium, spermatocytes. Then we will have the spermatids, and towards the lumen we will have the spermatozoa. Now, other options. So option A, spermatozoa is present at most of the luminal side and not just after myofibril. Spermatogonium is never inferior to primary spermatocyte, so it is also not correct. And myofibril is lying outside, most basal aspect or outside the spermatogonium. So option A, C and D is absolutely wrong. We have got the correct option as option B. Okay. So everyone, can we move to the next MCQ? Everyone, let's move on to the next. That is question number 7. Question number 7. Which of the following is not the content of ischiorectal fossa? Everyone, are you understanding? So everyone, are you understanding? Please ask your doubts. If you are not able to understand the other options, or if any doubt is there, you tell me. I will repeat it once again. Which of the following is not the content of ischiorectal fossa? The option given is inferior rectal nerve, posterior scrotal nerves, perineal branch of fourth sacral nerves, and superior rectal nerve. So actually, when I am talking about ischiorectal fossa, which is also termed as ischioanal fossa, it is lying on either side of anal sphincters. And it is embedded with fat. It contains a large amount of fat. So which of the following is not a content of ischiorectal fossa? Anuj Sharma has given his answer as D, superior rectal nerve. What about others? Anuj Chaudhary has given his answer as D. Okay. Okay, so most of you are giving the answers D. So it's absolutely correct. Yes, superior rectal nerve is not a content. So definitely for both of you, again a thumbs up goes. Both of you are again correct. So for this image, I would like to define the borders and the contents of ischiorectal fossa. So superior rectal nerve is not the content. Inferior rectal nerve, posterior scrotal or posterior labile, perineal branch of fourth sacral, all are the contents along with fat as the content of ischiorectal fossa. So basically, just a quick revision of the contents of ischiorectal fossa. So if I'm talking about ischiorectal fossa, it is having fat. So the first content will be ischiorectal pad of fat. It will also have inferior rectal nerves and vessels, which is running from lateral to medial. So there is inferior rectal nerves and vessel. Yes, Anuj Sharma, I will tell you about the apex. Apex is formed Actually, yes, Anuj Sharma, apex of ischorectal fossa is formed by the junction of levator ani muscle and obturator internus muscle fascia. So I will show you that. Okay, don't worry, I will show you that. Perineal branch of fourth sacral enters the posterior angle and it's actually reaching the levator ani. Posterior scrotal and labile nerves and the vessels is also lying. Yes, I will show you the meeting point of levator ani and obturator internus fascia. That is forming the apex. That is forming the apex of ischorectal fossa. Anuj Sharma, I will show you that image. Now see here. So this is a schematic diagram just to show you the contents of ischorectal fossa, ischorectal pad of fat, posterior labile nerves and the vessels, inferior rectal nerves and vessels, and also the perineal branch of fourth sacral nerve. Okay. Now, boundaries. So, okay, Anuj Sharma, just see here. If I am talking about boundaries of ischorectal fossa, anteriorly, we will have the urogenital diaphragm. So, posterior border of urogenital diaphragm. Can anybody tell me what is the content of urogenital diaphragm? Which two muscle is the content of urogenital diaphragm? Urogenital diaphragm is containing two muscle. What is their name? Urogenital diaphragm, two muscles. Name is deep transverse perineal muscle. What is the answer? Deep transverse perineal muscle and sphincter urethrae. Posteriorly, it is going till the level of sacrotuberous ligament and gluteus maximus muscle. So on the posterior aspect, there is gluteus maximus muscle, an important extensor of the hip, and sacrotuberous ligament. Medially, as I told you, levator ani is lying above and sphincter ani externus is below. Superiorly, yes, external urethral sphincter. Absolutely correct, Anuj. Yes. Sphincter urethrae, external, yes, sphincter urethrae, absolutely correct, dear. Yes, you are absolutely right. And also deep transverse perineal muscle. Now, superiorly or the apex, as I told you, actually it is extending on the inferior aspect of pelvic fascia. So, obturator fascia and the perineal covering of levator ani muscle. This is the location where the extent of the superior aspect of ischorectal fossa is extending till the junction where the levator ani fascia and obturator fascia is meeting. Inferiorly, there is perineal skin, perineal skin. Okay, dear. Okay. Now, just proceeding to the next MCQ, I would like to show you this schematic diagram where you can see the communications of each side of the ischorectal fossa. So, we can see the perianal skin is forming the floor. We can see lateral aspect. In the lateral canal, in the lateral aspect, there is also Alcock's canal. What is the other name of Alcock's canal? Alcock's canal is formed by the splitting of which fascia? Can anybody tell me? Alcock's canal is formed by the splitting of obturator fascia. And it is also called as pudendal canal. It is also called as pudendal canal. Apex is going up till the level where the levator ani and obturator internus fascia is meeting. And medially also there is external anal sphincter. Is it okay? Yes, Anuj Kumar Chaudhary, pudendal canal. Now let's move on to the next MCQ. Now before that, inferior rectal nerve is not the correct answer because inferior rectal nerves and vessels is definitely the content of ischorectal fossa. Same way, posterior scrotal nerves and labial, posterior scrotal and the labial nerves and vessels is also the content of ischorectal fossa. Perineal branch of fourth sacral nerve is also the content, so it is also not the correct answer here. Now let's move on to the next one. Yes, dear, let's move on to the next one. That is question number 8. A 38-year-old man is admitted to the hospital from the emergency department because of severe pain in the back and the left shoulder. So there is pain in the back and also in the left shoulder. A CT scan is revealing an abscess, and the abscess, what is the location of the abscess? The abscess is in the upper aspect of left kidney, but no abnormality is there in the shoulder region. The shoulder pain is caused by the irritation or inflammation of the neighboring structures. So we have to come to the most correct answer. Why there is irritation? So upper part of left kidney, no abnormality in the shoulder region. The pain is caused by inflammation of neighboring structure. So which of the following structure is the reason of pain in the back and the left shoulder? Yeah, that is the hint. Yes, phrenic nerve. Yeah, Anuj Kumar and Goswami, Anuj Sharma, absolutely correct. So this was slightly twisted, but again, I got a right answer from all of you. Yes, you are absolutely right. That diaphragm is the most correct answer. Absolutely correct, dear. Yes, dear, the diaphragm is the most correct answer. The pain is due to the irritation of the nerve. Yes, diaphragm is the most correct answer. I will also rule out the other option. So see here, the abscess is actually the abscess which is lying on the superior aspect of kidney is spreading to the diaphragm, because if I'm talking about the diaphragm, it lies in the close proximity of the superior poles of the kidney. If you remember, if I'm talking about the kidney's posterior relation, can you name the 4 muscular structure related posteriorly in the kidney? So from medial to lateral, there are 3 muscles, and the posterior superior also, there is another muscle that is called as diaphragm. Is it okay? Yes, dear Anu Sharma. So we have got diaphragm in the posterior superior relation close to the superior pole of the kidney. Also, we have got psoas major muscle, quadratus lumborum, transverse abdominis muscle. Diaphragm is innervated by C3, C4 and C5 nerve. And also, because of this region, the pain is the reason by involvement of phrenic nerve. So we will mark the correct answer as the diaphragm. Absolutely correct. Renal transplantation, when the renal transplantation is done, left kidney is preferred to be transplanted, and the reason is longer renal vein. The donor kidney is placed retroperitoneally in the iliac fossa, parallel to which vessel? External iliac vessels. Renal artery is anastomosed with the internal iliac artery, and renal vein is anastomosed to external iliac vein. So these are noteworthy points. I want everyone to please note that the donor's kidney will be retroperitoneally located in iliac fossa, parallel to external iliac vessels. Renal artery is anastomosed by which artery? Internal iliac artery. And renal vein is anastomosed to the side of external iliac vein. The ureter is implanted into urinary bladder, and this process is called as ureterocystotomy. Got it? Yes, quadratus lumborum, transverse abdominis, psoas major. Absolutely correct. All of you are absolutely correct for the relations of the muscles on the posterior surface and the relation of the muscle, that is diaphragm, on the superior aspect posteriorly. Descending colon, let us come to the incorrect answer. So descending colon is not the right answer. The reason is that it is innervated from the S2, S3, S4 nerves. Duodenum is innervated by vagus nerve, so it is also not the correct answer. And liver is innervated by the branch celiac ganglion parasympathetically by the vagus nerve. So they are not the right answer. So none of this is innervated by the phrenic nerve, and that is not the reason of referred pain to the shoulder. So everyone, is it okay? Can we move to the next MCQ? So let's move on to the next MCQ, that is the 9th one. So we have to complete 28 MCQs. Today, the target is to complete the 28 MCQs, actually small 28 topics. It means 28 topics of anatomy, which is very important for your INI CET exam. A 57-year-old woman is admitted to the emergency department with a severe swelling on the right side of her neck. An MRI examination reveals abscess. The abscess is surgically removed from the middle cervical triangle of the right side, posterior triangle of the right side. The hint given is the abscess is removed from the posterior cervical triangle of the right side. And during the recovery, the patient notices shoulder drops and she can no longer raise her right shoulder above the head to brush her hairs. So no brushing of the hairs can be. That means overhead abduction is involved. So what I am highlighting is the keywords which is marked in this MCQ. Which of the following nerves has not likely been injured in this case? Whether it is accessory nerve, whether it is ansa cervicalis, whether it is facial and hypoglossal nerve. So I got many of the students giving me the right answer as accessory nerve. Absolutely correct. Again, a thumbs up goes for you, and all of you are absolutely right. But I would like to give you the detailed anatomy of the posterior triangle of the neck. Actually, Can anybody tell me which fascia is forming the roof of posterior triangle? My question is, which fascia, which part of deep cervical fascia is forming the roof of posterior triangle, and which part of deep cervical fascia is forming the floor of posterior triangle of the neck? Anu sir, I will come to that. Don't worry. Yes, I will come to exactly the muscle being. So basically what happens, accessory nerve, the spinal accessory nerve. Basically when I'm talking about spinal accessory nerve, the spinal accessory nerve is sandwiched between, the roof and floor of posterior triangle of neck, and actually in between. So the roof is formed by investing layer of deep cervical fascia, and the floor muscles are covered by prevertebral layer of deep cervical fascia. So the course of spinal accessory nerve is that it is sandwiched between the two fascias, that is investing layer of deep cervical fascia and that of prevertebral layer of deep cervical fascia. So whenever, if there is any abscess in the posterior triangle of the neck, and if it is drained, proper care should be taken by the surgeon not to injure the accessory nerve, the spinal accessory nerve. If a spinal accessory nerve is injured, the muscle being paralyzed will be sternocleidomastoid and trapezius muscle. So my dear students, here the abnormality which is seen is overhead abduction, and we know that overhead abduction, that means abduction greater than 90 degree. So here overhead abduction, that is abduction greater than 90 degree, and this action is done by two muscle. One is trapezius muscle, which is injured in this case, along with SA. What do you mean by SA? Serratus anterior muscle. My dear student, what do you mean by SA? Serratus anterior muscle. So both this muscle is causing the action of overhead abduction. Now, in this case, as the injury is in the posterior triangle, that means the trapezius muscle is involved, and that is the reason of overhead abduction being lost. If procedures like which was performed in the axilla, for example, mastectomy operation in the breast cancer, and in that case there can be injury of long thoracic nerve, which is giving innervation to serratus anterior muscle, and then also the patient will have loss of overhead abduction, that is abduction greater than 90 degree, that is over above the horizontal level, and so only the patient is not able to brush her hairs. Yes, KK, you are absolutely right. Yes, KK, you are absolutely right that the roof is formed by the investing layer and the floor is formed by the prevertebral layer of deep cervical fascia. Spinal accessory nerve is passing across the posterior triangle of the neck and innervating two muscles, sternocleidomastoid and trapezius muscle. The muscle which is involved in this case is the trapezius muscle. For example, if there is involvement of sternocleidomastoid muscle, then there will be movement of the neck being affected. Trapezius will make the shoulder droop. Now, I just want everybody, so quickly go through the contents. I just want everybody, we know that there is inferior belly of omohyoid, and the inferior belly of omohyoid will divide the posterior triangle of the neck into two triangular space. The area of posterior triangle lying above inferior belly of omohyoid is occipital triangle, and the area of posterior triangle which is lying below inferior belly of omohyoid is the subclavian triangle. And individually, it's very important for your examination of INI CET that you should know the content of this triangular region. You should know the content of occipital triangle, and you should know the content of the subclavian triangle. The nerves, which is the content of the occipital triangle, is spinal accessory nerve, the four cutaneous branches of the cervical plexus. What is the four cutaneous nerve which is lying in the roof part? Is the lesser occipital having the root value C2, the great auricular C2 and C3, the supraclavicular nerve which is having three branches and going downwards, that is the supraclavicular nerve, and the cutaneous, transverse cutaneous nerve of the neck. Also, spinal accessory nerve, the branches directly of C3 and C4 branches to rhomboids, vessels may transfer cervical occipital, and also the lymph nodes are lying there, the supraclavicular lymph node. In the subclavian triangle, we have got trunks of brachial plexus, and the branch of trunk of brachial plexus, two branches from the trunk of brachial plexus, that is suprascapular and nerve to subclavis. Also long thoracic nerve, third part of subclavian artery, suprascapular artery, and few members of subclavian chains. And also we will have the subclavian vessels. Now, this is a schematic diagram of posterior triangles. This is a schematic diagram of posterior triangle of neck. And in this posterior triangle of the neck, we will have the upper region as the occipital triangle and below as the subclavian triangle. The muscle which is responsible for dividing the posterior triangle into two triangular space is the inferior belly of omohyoid. And individually, you have to know the content of upper triangular region and also you have to know the content of lower triangular region, that is the subclavian triangle. So actually, posterior triangle of neck, a very important topic, and I want everybody to know about this. So let's move on to the next one. Before that, why ansa cervicalis is not the right answer? Actually, ansa cervicalis is a nerve loop lying in the anterior wall of carotid sheath. Where is ansa cervicalis located? It's a nerve loop which is formed by the C1, C2 and C3 cervical nerves, and this is embedded in the anterior wall of carotid sheath. Ansa cervicalis is giving innervation to infrahyoid muscle. Infrahyoid muscle. Can anybody tell me all the infrahyoid muscle is supplied by ansa cervicalis except which infrahyoid muscle is not supplied by ansa cervicalis? There is one infrahyoid muscle which is not supplied by ansa cervicalis loop. It is directly supplied by C1 nerve carrying the fibers of hypoglossal nerve. Can anyone give me the answer? Also, facial nerve is not the right answer because it is not lying in the region of triangles of the neck. And also, hypoglossal nerve is not the right answer because if it is injured, it will lead to the paralysis of muscles of tongue. Okay, dear? So, can anybody tell me ansa cervicalis loop gives innervation to all infrahyoid muscle except one? What is the name? Stylohyoid. Anuj, no. The right answer, please note down all infrahyoid muscles are supplied by ansa cervicalis loop except which muscle? The right answer, any guesses, my dear students? The answer is thyrohyoid muscle. Because thyroid muscle is directly innervated by C1 nerves, getting the innervation via hypoglossal nerve. Okay, dear? So let's move on to the next MCQ. That is MCQ 10th. Everyone okay? A 35-year-old woman is admitted to the hospital with a sharp pain in the left lower quadrant. Patient history reveals that her last menstrual period was 10 days ago. Transvaginal ultrasound reveals a ruptured ovarian cyst is there on the left side. Yes, Anuj Sharma, you are absolutely right. Yes, Anuj Sharma is absolutely right for thyroid muscle, which was asked by me previously. Now, reveals a 90 ml of fluid is in the pelvis, which is present, and the content of cystic content and bleeding from the rupture side. So the fluid is collected on which of the following space? The fluid is collected in the subphrenic space, rectouterine pouch of Douglas, vesicouterine pouch, or paracolic gutter. So this is an easy one because it's clinically, you must have also gone through, you must have studied that the most dependent part of the pelvis and the collection of fluid will be in the rectouterine pouch of Douglas. So definitely the right answer is rectouterine pouch of Douglas. So all of you have given definitely the right answer. A thumbs up goes for you. Now, actually, the most likely location of fluid accumulation in this case is the rectouterine pouch of Douglas because this is the lowermost point of the pelvis when a person is lying in a standing erect position. This is the most dependent part of the pelvic cavity. The fluid here will accumulate because mesoovarian ligament causes the ovary to be located on the posterior aspect, and this allows communication of the fluid from the ovaries and the rectouterine pouch. Also, I would like to show you a sagittal section in which you can see this is the rectouterine pouch of Douglas. This is the space lying in between rectum posteriorly and the uterus anteriorly. Anterior to the uterus, we have got vesicouterine pouch, which is the space lying anterior to the uterus and that of in between urinary bladder and uterus. In this case, the rectouterine pouch of Douglas is infected and the collected fluid is lying there. Actually, if you want to drain, if we want to drain the fluid from the rectouterine pouch of Douglas, the approach will be through posterior fornix of vagina. So the surgeon or the gynecologist should approach this pouch, rectouterine pouch, proceeding the index finger through or proceeding it through the posterior fornix of vagina. The rectouterine pouch of Douglas is the most dependent part of the peritoneal cavity when the person is lying in the upright position. Supine position, it is the most dependent part of the pelvic cavity. So you can see the other abdominal space which is also affected is the hepatorenal pouch of Morrison's. In the supine position, which is hepatorenal pouch, the other space of the pelvis which is involved is rectouterine pouch of Douglas. Now, right subphrenic space is not the right answer because it is lying inferior to the right side of diaphragm and the location of this space is superior to liver. Same way, paracolic gutter is also not the right answer because it is lying lateral to ascending and descending colon. And less likely, the fluid is accumulated in this area. The vesicouterine pouch, as in the image I have shown you, vesicouterine pouch is lying anterior to the uterus and it is not involved in this case. Let's move on to the next one. Next clinical question. All of you, let's solve the next question, a clinical question, an important one. A 45-year-old man is admitted to the neurosurgical clinic for a scheduled removal of tumor in the left jugular canal. Now, post-operatively, the patient has no gag reflex when the ipsilateral pharyngeal wall is stimulated. Although the pharynx moves upward and a gag reflex resulted when the right pharyngeal wall was stimulated. So the uvula is deviated to the right and the left vocal cord is drifted towards the midline. Which of the following structure is containing neuronal cell bodies or motor supply of paralyzed muscle? Whether the right answer is nucleus solitarius, trigeminal motor nucleus, dorsal motor nucleus, or nucleus ambiguous. Actually, here the structure which involved is there is gag reflex. So you have to know the afferent and efferents of the gag reflex. Pharyngeal wall, also pharyngeal wall affected, right and left vocal cords drifted. So basically you can see the structure, the cell bodies of these structures will be involved, and we know that nucleus ambiguous is a composite nucleus of which cranial nerve? Can anybody tell me? Nucleus ambiguous is a composite nucleus of which cranial nerve? It is a composite nucleus of 9th, 10th and 11th cranial nerve, and it is very important for innervating the pharynx. It innervates pharynx, it innervates larynx, it innervates the soft palate. So it innervates the larynx, it innervates the soft palate, it innervates. So basically the right answer will be the nucleus ambiguous. Okay. Absolutely correct, dear. Absolutely. It is a composite nucleus for these structures. And according to the clinical history which is provided in this MCQ, it is quite clear. It is very clear that the pharynx is involved, the palate is involved, and definitely the correct answer will be nucleus ambiguous. Yes, KK, you are right. Yes, KK, you are right. So basically, glossopharyngeal nerve, vagus and cranial part of accessory is involved. Now, nucleus ambiguous give rise to the efferent motors of vagus nerve, which is giving innervation to the laryngeal and pharyngeal muscle. So, if it is involved, the cuff and gag reflex will be involved. The nucleus ambiguous lies in the medulla, as we know. Why it is called as ambiguous? Because in the cut section. Why this nucleus is called as nucleus ambiguous? As it is a composite nucleus of 9th, 10th and 11th, and when we see the transverse section of the medulla, it is ambiguous in location. It is not clearly visible. It is ambiguous. It is an elongated column lying in the both open and closed part of the medulla, and in section it is ambiguous, not clearly visible. Stylopharyngeus muscle is supplied by 9th cranial nerve. Muscles of soft palate, pharynx, larynx, all is supplied by vagus, along with which part of accessory nerve? Cranial part of accessory nerve. Always the cranial part of accessory nerve runs along with the vagus. The spinal part of accessory nerve gives innervation to that of the sternocleidomastoid and trapezius muscle, which is not involved in this case. So that is the reason we will mark the correct answer as nucleus ambiguous. Now, nucleus solitarius is not the right answer. Why? Because nucleus solitarius is located in the in brainstem and responsible for the visceral sensations, general and visceral sensations for the taste from facial, glossopharyngeal and vagus nerve. So this is mainly for taste sensation. So it is not the correct answer here. Trigeminal motor nucleus. When I am talking about the fifth cranial nerve, motor nucleus, we know that it is giving innervation to the muscles of mastications. And muscles of mastications, we have got 4 primary muscles of mastication: masseter, temporalis, medial and lateral pterygoid. It also innervates tensor tympani muscle, tensor villi palatini muscle. It also innervates mylohyoid muscle, and it also innervates the anterior belly of digastric muscle. So all these muscles are the muscles of first pharyngeal arch, which is innervated by the mandibular nerve, which is a branch of the trigeminal nerve, which is not the correct answer here. Dorsal motor nucleus is also not the correct answer. The reason is that dorsal motor nucleus contains cell bodies of preganglionic parasympathetic fibers of vagus nerve, and basically dorsal motor nucleus is involved in innervating the heart musculatures, the smooth musculatures of glands of the respiratory and intestinal tract, which is not the correct answer here. So we'll mark dorsal motor nucleus as the wrong option. Okay, dear. So let's move on to the next. Let's move on to the next MCQ. So I'm just checking your answers also. Let's move on to the next. So this is an image-based question. I would like to read it for you. Okay. A 33-year-old man is admitted to the hospital complaining of diplopia or the double vision while walking downstairs. Okay. During the physical examination of extraocular muscle, the patient experiences diplopia, and when he is asked to turn his right eye inward towards his nose and look down, he is able to look inward but not down. He is not able to look down. Which of the following is most likely involved nerve in this case? So we have got A, B, C, D. That means you have to identify. So actually what you can see in this image, my dear students, you can see the inferior view. You can see the inferior view of the brain, and you can see nerves emerging out has been labeled as A, B, C, D. So please mark the right answer, whether it is A, whether it is B, whether it is C or D. So all of you are telling D is the right answer. Okay, D is the right answer, and you are telling, okay. So everyone is telling D. Oculomotor nerve. No, see here, the patient is having double vision. Okay, double vision while walking downstairs. Extraocular muscles and diplopia is there. When he is turning his right eye inward, and he is able to look inward but not down, means not down, depression is affected. Actually, all of you are correct that, yes, most of you are correct, some of you, so actually not the option. Option is not the correct, but the answer is correct that the nerve, the muscle which is involved is superior oblique muscle. So actually oculomotor nerve will not be the right answer, because oculomotor nerve is innervating all extraocular muscle except LR6, lateral rectus, and that of superior. The muscle being affected here is superior oblique muscle, which is innervated by trochlear nerve. That means the correct answer is trochlear nerve. Now, my dear students, the trochlear nerve will be the right answer. Trochlear nerve is the right answer here. So trochlear nerve is which nerve? Is it D or B? It is D or B. B marked structure is trochlear nerve, dear. So B marked structure is the trochlear nerve. So when the third cranial nerve or oculomotor nerve, yes, Anuj Sharma, you're right that trochlear nerve is the right answer. But when we are talking about trochlear nerve is B structure. If the oculomotor nerve is involved, then the adduction of eye is not possible. The action of all extraocular muscle is gone, and but here the superior oblique muscle is involved, and generally the characteristic feature which is seen in the clinical condition of paralysis of superior oblique is that diplopia, double vision, and when he or she is walking downward, he is able to look inward is okay, but not able to look downward because superior oblique muscle is also causing depression of the eyeball. So here, is it okay? Yes, Anuj Kumar is telling dorsal origin. Yes, he is giving a very good, actually trochlear nerve is the only nerve which is originating from the dorsal aspect of brainstem. All other cranial nerve is originating. All other cranial nerve is originating from ventral aspect. Only trochlear nerve is from the dorsal aspect. After its origin from the dorsal aspect, the fibers decussate on the ventral aspect. Superior oblique muscle is turning the pupil down from the adducted position. Inability to perform this motion is diplopia when walking downstairs. When trochlear nerve is damaged, the person clinical feature, please, this is very, very important for the MCQ. The clinical feature which will be seen in the case, this can be also asked in the ophthalmology questions. Actually, the patient will have problem in looking down when he or she is walking downstairs. So diplopia occurs on looking downwards. Okay, that is it. Okay, Manish, got it. And the paralysis will result in diplopia and defective depression of the adducted eye. So only these two features were present in this case. So we'll mark trochlear nerve as the right answer. So we'll mark B. So here B is the trochlear nerve and B is the right answer. So B is the right answer. Okay, all other option, why A is not the correct answer? A is the wrong answer because A nerve is the olfactory nerve. And when A is involved, what will happen? The loss of smell will be there. The patient can have hyposmia, hypersomnia, anosmia. Such kind of clinical history was not given in this question. So definitely A is not the right answer. C is also the wrong because it is optic nerve. And this will be involving the vision. Traumatic optic neuropathy or vision will be involved. This was not clinical history of the patient. And also D, which most of you have marked, D is, my dear students, oculomotor nerve. And when oculomotor nerve is involved, medial rectus muscle paralyzed, superior rectus muscle paralyzed, inferior rectus muscle paralyzed, drooping of eyelid because of LPS, levator palpebral superioris muscle is paralyzed, inferior oblique is paralyzed. So the patient will have upward and inward movement of the eyeball, and this was not present in the case. So definitely this is not the right answer. So definitely in this case, B is the trochlear nerve. So we can write it, B is the trochlear nerve, A is the first cranial nerve, olfactory cranial nerve, C is the second cranial nerve, optic, and D is the third cranial nerve. Is it okay? So we have got the right answer as B. Got it, everyone? Can we move on to the next MCQ? Please let me know. I'm just checking your messages. Is it okay? Let's move on to the next MCQ. That is question number 13. Nerve supply of the muscle shown in the diagram. What is the nerve supply of the muscle shown in the diagram? Whether it is suprascapular nerve, whether it is dorsal scapular nerve, whether it is subscapular nerve, whether it is dorsal rami of C1. Okay, dear. So I just want everybody that you have to identify the green color muscle which is shown in this image, and then you have to give me the detail of the nerve supply. So basically, I would like to highlight, I will enlarge this image. So when I have enlarged this image, you can clearly appreciate which muscle is this. Can you tell me the name of the muscle? The hint is that you can see, this is the medial border of the scapula. This is the medial border of the scapula. So what is the name of this muscle? Question mark. What is the name of this muscle? Which muscle is this? Manisha, Devika, Anuj Kumar Chaudhary, Sarma. Which muscle is this? Yes, absolutely right answer. It is levator scapulae muscle. Yes, it is levator scapulae muscle. And levator scapulae muscle is innervated by dorsal scapular nerve. Absolutely correct answer. So we will have the right answer, dorsal scapular nerve. So we will have the right answer, that is dorsal scapular nerve. Levator scapulae, Devika is absolutely right. Actually, you can see the medial border of the scapula from the dorsal aspect has been shown, and from top to bottom, the muscle attached will be superiorly levator scapulae, and lower to it, we will have rhomboidus minor and major. On this, we will have rhomboidus minor and major. So rhomboidus minor will be above and major will be below. So see here. So I would like to show you this image where you can see where you can see that levator scapulae muscle is originating from the transverse process of C1 and C4 cervical vertebra. It is originating from the transverse process of C1, C2, C3, C4 cervical vertebra and inserting onto the superior angle of the scapula, as you can see from the dorsal aspect. This is the scapula dorsal aspect. And if I talk about innervation, it is having the innervation by dorsal scapular nerve, and not only this, it is also having innervation directly from third and fourth cervical nerve, also from third and fourth cervical nerve. So exactly the correct answer which will be chosen among the option provided will be the dorsal scapular nerve. So we have got dorsal scapular nerve as the right answer. Now, so can we go to the next one? Let's move on to the next MCQ. That is question number 14. A 6-year-old boy is brought to the plastic surgeon's office. He has got a small jaw, large mouth, flat cheeks bone, and malformed pinna. Actually, this clinical presentation is very important, that he is having a small jaw, large mouth, flat cheeks bones, and malformed pinna. Yes. So he has cleft palate at the birth, which is surgically corrected afterwards. Also, he was also having cleft palate. The parents complain that he does not respond when they want to talk to him. What is the embryological defect which is the reason in this case? Whether the child is having trisomy 13, whether the child is having defect in FB1 gene, failure of rostral neuropore, that is anterior neuropore to close, failure of neural crest migration to the first arch. So absolutely correct, Manisha, Goswami and Anuj. Absolutely correct. All of you are absolutely correct. Yes, the correct answer is Teachers-Collins syndrome. This is the failure of neural crest to migrate to the first arch. Actually, this is a first pharyngeal arch syndrome. This is a case of first pharyngeal arch syndrome. And the reason of first arch syndrome is the failure of migration of neural crest cells to the first arch. So we'll mark D as the right answer. Absolutely correct, KK. Absolutely correct, Manisha. Absolutely correct, Anuj Sharma. Now, let's have a slight discussion of Teachers-Collins syndrome. So we know that Teachers-Collins syndrome is an autosomal disorder which is characterized by malar hypoplasia, downward slanting palpable fissure. So when you see the person will have downward slanting palpable fissures, defect of external ears, pinna, and sometimes abnormality of the ears will be also seen. So the reason of Teachers-Collins syndrome is failure of neural crest cells migrating during the 4th week development, and that is the reason that it will be involved. It will be the correct answer. Actually, this can be also asked as a question of surgery or medicine. Now, the other options, why the other options are not correct? Yes, these are associated signs. So many of the students are giving their options. So these are associated. Most important characteristic features will be given to you so that you can mark the right answer. Now, before proceeding to the next question, I want to rule out trisomy 13, defect in FB1 gene, and failure of anterior rostral neuropore to close. So actually, trisomy 13, which is also called as Part2 syndrome, is not the right answer because this is a chromosomal disorder. And exactly the baby will have intellectual disability, microophthalmia, cleft lip and palate, and also brain and spinal cord anomalies. Such kind of history was not provided. So definitely option A, trisomy 13, is wrong. Defect in FB1 gene is also wrong because defect of FB1 gene is related with which syndrome? Marfan syndrome. Failure of rostral neuropore is also wrong because it will lead to the condition of anencephaly. So done with this. Now let's move on to the next MCQ. That is question number 15. Is it okay? Can we go to the next MCQ, everyone? The next MCQ is an image-based question. So let's solve it. The histopathology specimen from the autoscopy is received of a 24-year-old patient as shown in the image. The given structure is not found in which of the following structures? The fallopian tube, the uterine tube, that means epididymis, the bronchi, ependyma. So that means if I enlarge this image, you have to identify what is this structure. So can you see the black arrows, dear? Can you appreciate the black arrows? So you have to know what is this black arrow? What structure is the black arrow? What is that? This is via how you are going to identify. You can identify the epithelium, no? Epithelium is like that, and this is a projection from the apical part of the epithelium. So what is this? What is this? Can you tell me what is this black arrow structures? These are cilia. So that means this is actually ciliated columnar. Yes, pseudostratified ciliated or ciliated columnar epithelium. So basically cilia is the arrow mark structure. So we know that fallopian tube is having cilia. We know that the respiratory epithelium bronchi is having cilia, and ependyma, that is the lining epithelium of central canal of the spinal cord and the ventricles, is called as ependyma. What is ependyma, my dear students? Ependyma means the lining epithelium of central canal of the spinal cord and that of ventricles of the brain. So basically the correct answer will be epididymis. Epididymis is not having cilia. Can anybody tell me? Epididymis is not having cilia, but it is having one projections from the apical part. What is it called as? It is not having cilia, but it is having another structure. What is it called as? Yes, all of you are right that B is the right answer. But my question is, if it is not having cilia, what does the ependyma lining epithelium is having? What does the ependyma lining epithelium is having? My question is that. Epididymis. Waiting for your answer. It is not having cilia. But what does it has a lining epithelium? Anyone? Anyone? Stereocilia, yes, absolutely right. So I got an answer from Anuj Kumar. I got an answer from KK. I got an answer from Eva. I got an answer from Sarma. Yes, absolutely right. That is stereocilia. Is it mobile? It is having motility or not? Stereocilia is motile or not? It is long microvilli and it is not motile. Stereocilias are not motile, but cilias are motile. Yes, absolutely right. So my dear students, similar kind of histological image I have taken, and you can see the marked structure is the cilia, which is marked. These are all cilia. They are motile. This is pseudostratified ciliated columnar epithelium. The nucleus is at a various level. And pseudostratified ciliated columnar epithelium is found in the respiratory epithelium, and we have got cilia in the different parts. So motile cilia are located in several internal structures. It is located in the part of trachea, it is located in bronchi, it is located in the ependyma, it is located in the fallopian tube. So fallopian tube, bronchi, ependyma, all is lined by cilia. So they are all having cilia, but Stereocilia is present. So we know that in case of epididymis, we have got no cilia, but we have got stereocilia. So absolutely correct. And all these other structures is having cilia. So now let's move on to the next MCQ, that is MCQ number 16. Middle radioulnar joint is. Absolutely correct, everyone. Now, middle radioulnar joint is. My question is, middle radioulnar joint is plain synovial, primary cartilaginous joint, secondary cartilaginous joint, or fibrous joint? So yes, Anush, Shweta, everyone is telling fibrous joint. Can you tell me exactly the name of that joint? Yes, you are right that it is a fibrous joint. So which type of fibrous joint? Middle radioulnar joint. My question is, middle radioulnar joint is which type of joint? Middle radioulnar joint is a type of fibrous joint. Which variety? Absolutely correct. Yes, I got a right answer from Vijay Lakshmi KV. Yes, and this is syndesmosis type of fibrous joint. Syndesmosis type of fibrous joint. Absolutely correct there. This is syndesmosis type of fibrous joint. Absolutely correct. Absolutely correct, Vijay Lakshmi. You are absolutely correct, dear. Now, I would like to show you this image. Middle radioulnar joint is a variety of fibrous joint, and the articulation which is seen via interosseous membrane, which is actually forming a connecting link between the middle part of the shaft part of the radius and ulna, the forearm bone, is the syndesmosis type of fibrous joint. If we are talking about superior radioulnar joint and that of inferior radioulnar joint, both of these are which variety? Can anybody give me the answer? Both of these varieties are of which variety? Superior radioulnar and inferior radioulnar joint. Superior radioulnar and inferior radioulnar joint. So actually superior radioulnar joint is pivot type of synovial joint. Yes, absolutely right, Shweta. And inferior is also type of pivot type of synovial joint. But middle radioulnar joint will be a type of syndesmosis. Middle radioulnar joint is a type of syndesmosis. Absolutely correct. So we will mark fibrous joint as the right answer. Plain synovial joint is not the right answer because plain synovial joints examples are, plain synovial joint example is acromioclavicular joint, intercarpal, intertarsal, these kind of joint. So it is not right. Primary cartilaginous joint is an articulation which is seen between epiphysis and diaphysis of long bone. Secondary cartilaginous joints are midline joint in our body like pubic symphysis. So the correct answer is fibrous joint. So the correct answer will be fibrous joint. Now let's move on to the next. Everyone, is it okay? Can we move to the next? Krishna, yes, Krishna, God bless you. Yes, I'm so happy. Krishna has joined in hospital and cleared his exam. So congratulations to him. Let's move on to the next. Let's move on to the other options. Okay. So yes, we have got middle radioulnar joint as syndesmosis. So all the other options are absolutely wrong. And we have got the right answer as syndesmosis. Now let's move on to the next MCQ. That is question number 17. Question number 17. Action of the muscle at the hip attached to the marked area. So this is an image-based question and you have to first understand what is that arrow marked area. First, you have to know what is that arrow marked area. And you can see the bone which is shown to you is the femur bone. You have to identify that arrow marked area. Then you have to know about the muscle. Actually, this is a mixture of three MCQs. First will be image where you are going to identify that roughened area, which is black arrow marked area. Then you have to know the muscle attached on that area. Then you have to know the action of the muscle of that area. Option is abduction, external rotation, extension and lateral rotation, extension, adduction and lateral rotation, flexion and abduction. So what is that area? Yes, Shweta, you are absolutely right. The area is gluteal. Yes, you are absolutely right. That area is gluteal tuberosity. Yes, so this arrow marked area is absolutely correct, dear. Gluteal tuberosity. Yes, everyone is absolutely correct that this is gluteal tuberosity, part of the femur. Can you tell me which muscle is attached? Gluteus maximus. Goswami is telling gluteus maximus. Absolutely correct. So gluteus maximus is attached on it. Yes, absolutely correct. Now my next question is that what is the action of gluteus maximus? So we know that the action of gluteus maximus, it's a strong extension, and it also causes slight lateral rotation. So yes, B will be the right answer, and I think many of the students has marked B as the right answer. Absolutely correct. Yes, B is the right answer, and we know that extension and lateral rotation is the action of the muscle marked on this area, that is gluteus maximus. Now, can you tell me that gluteus maximus is inserted on the gluteal tuberosity of femur, but which other area? What is the major part of gluteus maximus is inserting into which area? My question to you is, major part of gluteus maximus is inserting into which area? Major part of gluteus maximus is inserting into which area? Major part of gluteus maximus is inserting into which area? That is my question. Okay, yes, you are right that gluteus maximus is inserting into gluteal tuberosity. But major part of gluteus maximus is inserting into which structure? Iliotibial tract. Yeah, KK, a thumbs up goes for you. So here comes KK with the right answer, iliotibial tract. Absolutely correct. Iliotibial tract. Major part of gluteus maximus is inserting into iliotibial tract. Can you tell me the name of other muscle which also inserts into iliotibial tract? The name of other muscle which also insert. Actually, why I am practicing these all correlated points? Because mainly the topics are repeated in INI CET, but not the same question. Always what you will see, the previous 5-year question, I want everybody to solve previous 5-year question, or maybe I only will come with previous 5-year questions of INI CET exam and explanation. Topics are repeated, but not the same question being repeated. So I am correlating it. Okay. Yes, gluteal tuberosity is the insertion for the gluteus maximus, and the other part of gluteus maximus is inserting into iliotibial tract. The other muscle which is inserting is the tensor fascia lata. Yes, Anuj Kumar Chaudhary, you are absolutely right. The other muscle inserting is the tensor fascia lata. Yes. So that is absolutely right. Now the marked structure is gluteal tuberosity as shown in the image. You can see and we know that gluteus maximus is attached here. So in this image, we can see the gluteal tuberosity. This line which you are seeing is the gluteal tuberosity. The greater and the lesser trochanters, the head and neck of the femur has been shown, and the structure inserting will be the gluteus maximus. So before proceeding to the next MCQ, let's quickly see all the important facts about gluteus maximus muscle. It is originating from the posterior surface of the sacrum, coccyx bone, the tailbone, and it also originates from the gluteal surface of ilium. It also originates from the gluteal surface of ilium, also a part of it from the sacrotuberous ligament and thoracolumbar fascia. Insertion, as I told you, the insertion is iliotibial tract and the gluteal tuberosity of the femur. The action is, it's a very important hip extension. It's an important and a strong hip extension and anti-gravity muscle. And it is also involved in external rotation, which is also called as the lateral rotation. What is the nerve supply? The nerve supply of gluteus maximus will be the inferior gluteal nerve, and its arterial supply is from inferior gluteal and superior gluteal artery. Can you tell me the nerve supply of gluteus medius and minimus muscle? What is the nerve supply of gluteus medius and minimus muscle? What is the nerve supply of gluteus medius and minimus muscle? That is superior gluteal nerve. That is superior gluteal nerve. And which sign is positive if superior gluteal nerve is injured? Superior gluteal nerve is injured. Which sign is positive? My question is, if superior gluteal nerve is injured, so which sign will be present? Which sign is positive? Yes, KK, you're right. Superior gluteal nerve. And superior gluteal nerve is innervating gluteus medius and minimus. And which sign is positive? Absolutely correct. The sign positive is Trendelenburg sign. And what is the primary action of gluteus medius and minimus? They are, what is the primary action, my dear students? They are hip abductors. They are hip abductors. So, if you tell the patient to stand on one leg, he is not able to balance the other side of the hip and it will sag down, and that is the case of Trendelenburg sign positive. Yes, dear, absolutely correct. Now, let's move on to the next. Question number 80. Yes, dear, absolutely correct. Again, a thumbs up goes for you. Now, my next, so we have got a total of 28 MCQs. So I think few more MCQs are there. So 10 more MCQs. So we will quickly solve the 10 more MCQs. So let's come up with the question number 18. Medial lemniscus is formed from which of the following? Fasciculus, gracilis, and the cuneatus, spinothalamic tract, spinocerebral tract, tectospinal tract. Medial lemniscus. So it's a direct MCQ. It is formed mainly from which part? First, second, third, or fourth? Fasciculus, gracilis, cuneatus, spinothalamic, spinocerebral, or tectospinal. So I think many of the students has already come with their correct answer. So absolutely correct. Yes, the correct answer is the fasciculus, gracilis, and cuneatus. Absolutely correct. Yes, this is the right answer, my dear students. So I just want, before proceeding to the next, just quickly have a discussion of the fibers of how this tract is formed. So basically, fibers of the fasciculus, gracilis, and cuneatus will terminate in which nucleus? They will terminate in nucleus gracilis and nucleus cuneatus. Now, the axon of second order neurons, which is arising. So now, if I am talking about second order neurons, these are second order neurons are arising from the nucleus gracilis and nucleus cuneatus, will move more ventromedially and will be forming internal arcuate fibers, sensory decussation. They will form internal arcuate fibers, and this will undergo arcuate fibers, and this will undergo sensory decussation, which is seen at the level of transverse section of the medulla. So when we see the transverse section of medulla, we can appreciate the second order sensory neurons arising from nucleus gracilis and nucleus cuneatus is forming internal arcuate fibers, which is undergoing the decussation. Thereafter, the fibers, after crossing the midline, will form a tract that is medial lemniscus. It will form medial lemniscus, which has been asked in the MCQ, and will terminate in which nucleus of the thalamus? So it will terminate in the ventroposterolateral nucleus of thalamus. Okay? Is it okay? It will be terminating into the ventroposterolateral thalamus nucleus, and the third order sensory neurons will be projected into the cerebral cortex. This is very important for carrying the sensation of which all sensation it carries, my dear students. It will carry out the sensation of conscious proprioceptive sensation, and they are together called as dorsal column medial lemniscus pathway. So they are called as or termed as the medial lemniscus pathway. So this was exactly asked in the MCQ, and definitely the correct answer is fasciculus, gracilis, and cuneatus. So basically, the other options are wrong because none of these are, none of these are forming medial lemniscus tract. Basically, it is formed by internal arcuate fibers, and basically they are coursing through the ventroposterolateral nucleus of thalamus. So absolutely option B, C, D are wrong. So this was a clear-cut direct MCQ. In short, I have also told you about the medial lemniscus, how it is formed and where it is the first order, the second order, and third order sensory neurons. I want everybody to go through this flow chart which I have made. You should go through this flow chart and you should know the first order, the second order, the sensory, third order sensory neurons, and you should also know what is internal arcuate fibers. Okay. Okay. Yes, medial lemniscus is formed and then it will form the third order sensory neurons. Yes, dear. Yes, Manisha, you're right. Second order sensory neurons is arising from here, and then third order sensory neurons will be in the thalamus. Okay. So that is arising from nucleus gracilis and cuneatus. Third order will be in the thalamus. Yes, dear. So everyone, can we move on to the next one? Manisha, Anuj Sarma, can we move to the next one? Next one. Okay. Okay, got it. Now let's move on to the next. That is question number 19. So yes, is it okay, Manisha? Yes, it is second order. Manisha, is it okay? Yes, it is second order medial lemniscus. Don't get confused with the fibers arising from the second order neuron. Okay, it is second order. Medial lemniscus is the second order. Yes. Now coming to the 19, identify the pariform fossa in the given image. A, B, C, D. So actually for the correct answer here, I want everybody just to, I will highlight this image so that you can know what is A, what is B, C and D. So you have to just identify the pariform fossa in this given image. What is pariform fossa? We know that it is a secondary, it is the second food channel. A, B, C, D. So if you want, I can just enlarge this image. I have enlarged this image for you. So just see this image. Now you can give me piriform fossa is A, B, C or D. So I have enlarged this image for you. Actually, piriform fossa, the other hint which I am providing to you is a secondary food channel. It is also called a smuggler fossa. Whether it is A, whether it is B, whether it is C and D. I want everybody to identify. So A is epiglottis. Manisha is telling A is epiglottis. So Manisha, you are absolutely correct. Yes, A, you are right that it is epiglottis. Yes, dear, A is right that it is epiglottis. So yes, Manisha has come up with her answer that A is epiglottis and C is telling that B will be the right answer. Okay. Okay. What about others? I will explain it. Don't worry. I will explain it. Don't worry. So basically, yes, B is the right answer also, that B is the piriform, it's the piriform fossa. But I want everybody, Anuj Sama, absolutely correct, but I want everybody also to identify what is C and what is D. Okay, let's come up with this image. So basically, we know that here this means 1, this means 2, this means 2, this means 3, C, and this means 4. So actually, if you will see this image, you can clearly see here A. What is A marked structure? A is the epiglottis. A is one of the laryngeal cartilage, that is epiglottis. Actually, epiglottis is containing, epiglottis is an example of which cartilage? Can anybody tell me epiglottis is an example of which? So it is a leaf-like structure. It is a leaf-like structure on the posterior aspect of the tongue, like a flap. And it is an example of elastic cartilage. So the most easy was to identify. Yes. And if I'm talking about fourth, this is aryepiglottic fold. Yes, absolutely right. It is aryepiglottic Glottic fold. Yes, it is lying close to the epiglottis, so it is ariepiglottic fold. And we can see this area is called as the lateral food channel. This is the lateral food channel. This is the second. So this is pariform. This is pariform fossa. Absolutely right. This is the pariform fossa. And if I'm talking about this is the false vocal fold. This is the ventricular fold. This is the false vocal cord false. So basically, the right answer will be B, pariform sinus. Is this okay? Yes, elastic cartilage is absolutely right. Yes, yes, dear. Elastic cartilage is absolutely right. Other example of elastic cartilage in laryngeal cartilage will be corniculate and cuneiform cartilage. Thyroid and cricoid and major part of arytenoid cartilage is hyaline cartilage, except the apical part of arytenoid cartilage. The apical part of arytenoid cartilage is again an example of elastic cartilage. So pariform, if I'm talking about pariform fossa, the pariform fossa is a potential space which is lying as a lateral side to the larynx, and it is 2 in number on either side. So it is a pyramidal shape structure, and it is deeper in the lower part but shallow in the upper part. Actually, what is the importance of pariform fossa? If sometimes what happens, if you are intoxicated or sometimes fish bone or any foreign body is there in this area, there can be a chance of injury of the nerve. What is the nerve which can be injured in the pariform fossa? That is internal laryngeal nerve. And my dear students, internal laryngeal nerves can be accidentally injured if there is any fish bone is there located, if a foreign body, and if we remove that structure from pariform fossa, and there can be iatrogenic injury to internal laryngeal nerve, which can lead to the sensory loss. Yes, you are absolutely right. This can lead to sensory loss in upper laryngeal cavity, in upper part of laryngeal cavity. And this can lead to loss of protective cuff reflex, and it can lead to asphyxia, suffocation. Protective cuff reflex can be lost. So boundaries, it is also important to know the boundaries of pariform fossa. The pariform fossa is bounded by mucosa over the lamina of thyroid cartilage on the lateral aspect. Medially, it is having arytenoid cartilage and cricoid cartilage, and superiorly, it is having pharyngoepiglottic fold. Pharyngoepiglottic fold. So the correct answer is pariform fossa, which is marked here as the B. So we will have B as the right answer, and few of you have given absolutely correct answer. Absolutely correct. Let's move on to the next question, question number 20th. Difference between, what is the difference between exocrine pancreas and the parotid? What is the difference between exocrine pancreas and the parotid? A, absence of striated duct, presence of acidophilic serous acinus at the tip, serous acini supported by basal lamina, apical acinar villi. So which is the most correct difference between exocrine pancreas and parotid gland? So actually, why this MCQ? This is again an MCQ of histology part. Actually, there is certain differences, which is, if you will see the pancreas slide, it will have both exocrine and endocrine part. The endocrine of pancreas is formed by islets of Langerhans. Exocrine part is formed by serous acini. And if I talk about the parotid gland, it is predominantly serous type. But there is difference between the serous part of pancreas and that of parotid gland. So that is the hint which is given to you to mark the right answer. So I got a right answer from Eva, Anuj, Manisha. Absolutely correct. Yes, A is the right answer. Anuj Sharma is also right. Absolutely correct. The absence of striated duct. Actually, when I'm talking about the pancreas, they are not having striated duct. There is absence of striated duct. Actually, the serous part or the exocrine part of pancreas is having duct which is arising from the interior of acini. Can you name that? Can you name it? The duct of exocrine part of pancreas is arising from the interior of acini, and this is termed, this is given a term which is only present in the exocrine part of pancreas. What is it called as? Anyone? Actually, the duct of exocrine pancreas is arising from the interior of SNI, and that is called as a cell that is present only in the pancreas exocrine. What is it called as? That is called as centroacinar cells. So that is centroacinar cells, which is present in the pancreas. The correct answer is A, absence of striated duct. Striated duct is not present in the exocrine part of pancreas. Now, parotid gland, if I'm talking of parotid gland, it is having both striated and intercalated intralobular duct. And if I'm talking about the pancreas is only having intercalated type, and it is also having centroacinar cells. The exocrine pancreatic duct are striated columnar, whereas our excretory part is simple columnar. So actually, this is the differences which we can appreciate in the exocrine part of pancreas and that of parotid gland. The pancreas endocrine part is formed by islets of Langerhans, which is not present in pancreas, which is not present in parotid gland. Actually, why pancreas is a both exo and endo? Because endocrine part is islets of Langerhans and exocrine part is serous acini. I would like to show you the parotid gland slide. So when you see the parotid gland slide, you can see so many acinas are there. Serous acini. So many serous acini is there. Duct is there. There is intercalated duct. There is striated duct. Interlobar duct. So actually, when you see the slide of parotid gland, it is predominantly serous. Also, when you see the high power of the, so see here, it is the high power view of the acinus. So you can see the contractile cells will be lying. There will be contraction. There will be contraction of the acinus, serous acini, so that it can release its secretion. And that contraction is done by myoepithelial cells, which is contractile cells. This is intercalated duct, the initial part of the duct, the striated duct, the interlobe. Actually, the height of ducts will be increasing as you proceed away from the acini. You proceed away from the acinus, the height of the duct's epithelium will increase, and ultimately the main exocrine duct will have striated cuboidal columnar type, or the largest duct will be having more height of the epithelium. The presence of acidophilic acinus is present in both, so it is not apical villi and serous acini supported by basal lamina. These are present in both exo and endocrine part. Parotid gland is having both type of striated and intercalated duct, but pancreas is having only intercalated duct. So we have got B, C, D option wrong. Now, before proceeding to the next MCQ, I want everybody to see also the histology of pancreas. So when you see the histological view of pancreas, what you can see, this is the endocrine part, which will be lighter in stain and which will have the acidophilic, which will have cells which is secreting the islets of Langerhans, the beta cells, and also alpha cells and somatostatin. And other than that, you can see there will be serous acini, and there is centroacinar acini. So centroacinar acini will be arising from interior of the acini, and there will be duct, but there will be absence of striated duct. So is it okay? Have you understood, my dear students? Can we proceed to the next MCQ? Can we proceed to the next MCQ, everyone? Is it okay, everyone? Can we proceed to the next MCQ? Okay. So let's come to the question number 21. Which of the following are branches of anterior division of internal iliac artery? Whether it is superior gluteal artery, whether it is inferior gluteal artery, whether it is superior vesical artery, middle rectal, inferior vesical vaginal. So actually, we know that internal iliac artery is a branch from common iliac artery. Common iliac artery bifurcate into external iliac artery and internal iliac artery. The branches of internal iliac artery will provide arterial supply to the pelvic structures, and external iliac artery will traverse downwards below inguinal ligament. It will be named as femoral artery. Now you have to tell me the correct answer. Which of the following? We know that internal iliac artery has got anterior division and posterior divisions. So it is very important that you should know the branches from individual part of internal iliac artery. So you have to go with the most correct answer. Anuj and Manisha has given the answers. What about others? Select the correct answer from the given below code. So actually, yes, 2 is definitely right answer, because the reason is that this inferior gluteal, superior vesicle, middle rectal, inferior vesicle, vaginal, all these are branches from anterior division of, all these are the branches from anterior division of internal iliac artery. Superior gluteal artery is a branch from posterior division of internal iliac artery. Absolutely correct. Actually, the mnemonic of branch from posterior division of internal iliac artery is, if we are talking about mnemonic of branches from posterior division of internal iliac artery, it is SIL. Branches from posterior division of internal iliac artery will be memorized by a mnemonic SIL, SIL, SIL. So here S stands for SIL. S stands for superior gluteal artery. I for iliolumbar artery. And L for lateral sacral artery. Lateral sacral artery. So that is the reason we will have 2 as the right answer. So Anuj Sharma, Anuj Kumar Chaudhary, absolutely right. You have given the name of the branches from the posterior division of internal iliac artery, and all of you are absolutely correct. So it is important that you should revise all the branches, name of all the branches from anterior division of internal iliac artery. So actually, when we are talking about the branches from internal iliac artery, the easy way to memorize is, there is three visceral parietals and the arteries group. So umbilical artery is there, superior and inferior vesical arteries are there, uterine, vaginal, middle rectal artery, obturator, internal pudendal, and inferior gluteal artery. So all these arteries are the branches from the anterior division of internal iliac artery. And 3 branches from the posterior division is SIL, SIL. S for superior gluteal, I for iliolumbar artery, and L for lateral sacral artery. So when you see this image, you can see the branches of internal iliac artery. So here, the branches from anterior division is obliterated umbilical artery, which is forming medial umbilical ligament. Again, an important point for your MCQ. Superior vesicle obturator, vaginal and inferior vesical artery, uterine artery or artery to ductus deferens in case of males, middle rectal, internal pudendal artery. These 3 are the branches from posterior division of internal iliac artery. That is superior gluteal arteries, lateral sacral artery, and iliolumbar artery. So this is also the branch. Inferior gluteal is also the branch from the anterior division. Superior gluteal, lateral sacral, and iliolumbar. So I think it's okay. We have number of times we have revised this point of the branches of internal iliac artery. I want everybody to memorize this. This can be asked as once more. So it's very important that you should know the branches of internal iliac artery. Now proceeding to the next MCQ, question number 22. In subclavian artery block, which is occurring at the outer border of first rib, which of the following arteries help in maintaining the circulation to the upper limb? The option is suprascapular artery, superior thoracic artery, thyrocervical trunk, subscapular artery. Select the order of correct answer as given below. So subclavian artery. So that means you have to know the arteries which is forming scapular anastomosis. What is the hint given to you? You have to name the arteries which is forming scapular anastomosis. So which among the following is not maintaining collateral circulation on the scapula? Okay, Manisha, ma'am, please revise medial umbilical and median umbilical ligament. Okay, sure, sure. So here, so we are coming to this option. Don't worry, we are coming to question number 22. But I got doubt from Manisha. Yes, Manisha, you want me to revise it? Okay, please write down. So Manisha, please note down. Yes, it is very important. Median. So median, Manisha, this is for you. Median umbilical ligament. Median umbilical ligament is remnant of is a remnant of urachus that is connecting apex of urinary bladder, that is connecting apex of urinary bladder to umbilicus. Okay, okay, Manisha. And when I'm talking about, this is one median, this will be 1 in number. When I'm talking about medial umbilical ligament, it is the remnant of umbilical artery, obliterated umbilical artery. This is 2 in number. This is 2 in number. Other than that, one more structure is attached to the umbilicus, that is falciform ligament. So inferior aspect of falciform ligament is having ligamentum teres, which contains left umbilical vein. Okay. So few more, I just want to revise everything. So yes, there is a ligamentum teres. Please note down ligamentum teres. So write down ligamentum. Actually, this I am telling you about the remnants of the umbilicus. So it's very important. These are the remnants of the umbilicus. So one more remnant is the ligamentum teres. Actually, ligamentum teres is present in the free margin of the falciform ligament, and it is the remnant of umbilical vein. It is the remnant of umbilical vein. Okay, and other than that, there is one more. So there is one more, that is the lateral umbilical fold. Lateral umbilical fold. I'm just utilizing lateral umbilical fold. This is also 2 in number, and lateral umbilical fold is a fold which is lying over, it's a fold which is lying over inferior epigastric vessels. Inferior epigastric vessels. Is it okay, everyone? It is a fold which is lying over inferior epigastric vessels. Everyone, I will just check. Actually, why it is important that you should know this? Because these are the remnants. Actually, why it is very important? Because these are the remnants at a level of umbilicus and has been asked number of times in the MCQ. So yes, Manisha has asked a very important thing. So once more, median umbilical ligament is the remnant of urachus, the Allen twice, which is connecting the apex of urinary bladder to the umbilicus. The ligamentum teres is the remnant of umbilical vein. Medial umbilical ligament is the remnant of obliterated umbilical artery. And lateral umbilical fold is lying over inferior epigastric vessels. Okay, done with this. Now we are coming up with the next question, that is question number 22. Now we are coming. So now I just want everybody to give me the answers of question number 22. Let me just connect, see it. Okay, dear. Okay, dear. Can anybody? So I got a mixed answer. Anuj is telling 2 and Eva is telling 4. Okay. So actually in subclavian artery block. So first thing is that for the correct answer here, you have to know basically the scapular anastomosis, which is taking place at the back in the scapula, and which of the following artery is not contributing and other arteries are contributing. So you have to give me the right answer. Help in maintaining. So there is one artery in this whole combination which is not contributing in forming scapular anastomosis. So please mark the right answer. I will just wait for a few seconds, 30 seconds, and then I will come up with the explanation. So yes, dear, the right answer is Anuj is telling 2. So 2, Eva is telling 4. Anyone? Anyone else? So superior thoracic artery, can anybody tell me superior thoracic artery is contributing in scapular anastomosis? Superior thoracic artery is branch of first part of axillary artery, and it is not contributing to the scapular anastomosis. So the right combination will be 1, 3 and 4. So the right answer will be 2. So those who have given 2 as the right answer is absolutely correct. Yes, 2. So Manisha, Anuj, everyone has given the right answer. Absolutely correct. 2 is the right answer, dear. Yes, 2 is the right answer. Superior thoracic artery or supreme thoracic artery is a branch of first part of axillary artery, and it is not contributing in the scapular anastomosis. If I talk about the scapular anastomosis which is taking place, it is via the branches of first part of subclavian artery and third part of axillary artery. So we will have the correct answer as second combination. Now I will show you an image for it and explain it. Before that, a rich anastomosis is there between the branches of first part of subclavian artery and the axillary artery. Actually, the anastomosis is taking place at two location, body and acromion process. So basically the branches of the subclavian artery first part are the branches from thyrocervical trunk. So basically thyrocervical trunk, branch superior thoracic artery, suprascapular artery and deep branch of transverse cervical artery are the branches from subclavian artery which is contributing, and branches of axillary artery third part is mainly contributing. Also one branch from thoracoacromial artery. They are subscapular artery, posterior circumflex humeral and thoracoacromial artery. So it's very important that you should memorize the name of branches from the first part, that is the proximal part of subclavian artery, and the branches from the distal or third part of axillary artery which is anastomosing. I just want everybody to see this image. So this is an image which is showing scapular anastomosis. So in this diagram, you can see suprascapular artery, branch from thyrocervical trunk, branch from dorsal scapular artery. So basically, mainly the branch of suprascapular artery, also anastomosis where is seen circumflex scapular branch of subscapular artery, posterior circumflex humeral artery, branch from that of thoracoacromial artery. All these are anastomosing in the scapula. So actually, the right answer here will be the suprascapular branch from thyrocervical trunk, branch from the first part of subclavian, and subscapular artery branch from the third part of axillary artery. So the odd man out is just 2, that is superior thoracic artery. So yes, all of you have given absolutely right answer. Now we will move on to the next MCQ, that is MCQ number 20. Is it okay? Can we go to next MCQ? Please let me know, my dear students. Everyone, please let me know. Can we move on to the next MCQ? Question number 23. Is it okay? 23. So just 5 more MCQs. So we have got just 5 more MCQs. So just 5 more MCQs. So actually it's an image-based question and you have to mark the right answer. It's a question from the NEET PG exam asked in the previous session. Okay, repeat question. So it's very important that you should know this image. Identify the correct diagnosis of the given image of the newborn baby as shown in the image, as it is the case of omphalocele, gastrocystis, extrophy of the bladder, Mickel's diverticulum. So you have to mark the right answer here. So Anuj and Eva and Anuj Kumar Chaudhary, Goswami, Sharma, they are all giving one as a right answer. They are all telling extrophy of bladder. So yes, KK is also telling extrophy of bladder, and definitely it's a correct answer. You must have got this question in pediatrics paper also. Yes, this is the image of extrophy of bladder. The bladder is protruded outside. So yes, dear, all of you are absolutely correct. Now see here, extrophy of bladder is also called as ectopia vesicae. Vesicae means bladder. And actually in this condition, the anterior abdominal wall in the anterior aspect of urinary bladder is absent. So the mucosal surface of the posterior wall of urinary bladder is showing the ureteric orifices and they are exposed. Yes, yes, KK, it is NEET PG 2022 previous question. Yes. So it's important that when you are going to appear for INI CET exam, previous year of NEET PG examination should also be solved. So what I feel, five years question papers of NEET PG and 5-year question papers of INI CET, आपको solve करना, you have to solve it before your exam. The urine can be seen dribbling intermittently from the ureteric orifices. Omphalocele is not the right answer. The reason is that omphalocele is actually a ventral body wall defect in which the failure of physiological herniated loops of bowel to return the body cavity has to happen, which not happens by the 11th week of intrauterine life. So basically, you can see there is two images. One is the case where omphalocele is herniated through the umbilical ring and having a translucent peritoneal membrane which is surrounding it. Okay. Omphalocele is the failure or the defect of physiological herniated loop not returning back to the body. Okay. And the other case is of gastrotrichus. So I will come to that. Omphalocele occurs when the body content herniating through the umbilical ring. It is covered by a membrane. A light gray shiny membrane is there. Translucent peritoneal membrane is there, as you can see. This is the membrane. And this is the case of gastrotrichus. So this occurs by a defect in the ventral body wall. And usually the defect is right to the umbilicus. And it will have a massive eversification of eviscerations of the intestine which can be involved, and it is not covered by a peritoneum. It can have adhesions also. So it is not having a peritoneum covering. It is slightly not exactly in the midline. It is slightly right hand side. It is not having any peritoneal membrane coverings. Now moving to the next one, question number 24. So yes, dear, just 5 more MCQs. A 32-year-old patient with a motor vehicle accident presented to the casualty with a fracture of superior pubic ramus and the fracture of pubic symphysis. His vitals are stable, but he is unable to pass urine. He has blood at the tip of the meatus as shown in the image given. What is the likely the cause of injury? Whether in this case the membranous urethra is injured, the penile, the bulbar or the spongy urethra. Okay, please mark the right answer, dear. If you want, you can see this image. The ramus of the pubis is injured, fractured in this case, and you have to tell which part of the urethra is injured. Actually, the keywords which is given here is the fracture of the ramus of the pubis and pubic symphysis. So I got multiple answers: bulbar urethra and membranous urethra. Actually, it's a more grave injury, and if I have to choose the most correct, I will go with membranous urethra. We know that bulbar urethra is more common, but here the pubis is involved, and here the injury will be in the membranous part of urethra, which is traversing through urogenital diaphragm. So I just want everybody to give you a differentiating feature of the two injuries of the urethra, the bulbar and the membranous. The superior ramus of the pubis is involved, and there will be the injury which is occurring above the urogenital diaphragm, and it will involve the membranous urethra. The rupture of urethra leads to, if the membranous urethra is injured above the level in the urogenital diaphragm, they can cause the extravasation of the urine and the blood into the tissues. Basically, they will cause deep extravasations. So basically, commonest cause of injury will be the bulbar urethra, in which the superficial perineal pouch will have the collection of the urine and the blood. But when there is membranous urethra, so these 2 points are very, very important for your examination. Urine extravasation will happen in the superficial perineal pouch, if the injury is below the urogenital diaphragm layer, which the injury is below or in the bulbar part of the urethra, so it will have the collection of fluid in the scrotum, penis, also in the anterior abdominal wall, deep to the membranous layer. That means the extravasation will be superficial extravasation. But if the urethra is injured above the urogenital diaphragm or in the urogenital diaphragm, causing the injury of membranous urethra, the deep perineal pouch will have the fluid, and that is called extraperitoneal space involved, and that is called as deep extravasation. See here, rupture of urethra, and if the membranous part of urethra is involved, that means membranous part is involved above or in the urogenital diaphragm, and the common injury is in the bulbar urethra. So actually two images I want you to show. In this first image, what you can see, there is injury of bulbar urethra. So the collection of fluid will be just in the superficial perineal pouch in below the anterior abdominal wall, and this is the injury of membranous urethra, and where there will be the extravasation of urine by the rupture of membranous urethra in the deep tissues, in the extraperitoneal space. This is the urogenital diaphragm. Below it, the bulbar urethra is injured, and above it, or if the injury is to the membranous urethra. Now let's move on to the next MCQ. Everyone, let's move on to the next. Which of the following structure is involved for the condition as shown in the image? So you can see the image is showing one of the condition of the breast. Can you tell me whether the condition is due to the involvement of Cooper's ligament, subdermal lymphatic drainage, carpa fascia, or pectoralis major muscle is involved in this case? So you just identify the case. Firstly, you can give the name of the case, and then you can see the structure being involved. Everyone is giving same answer. Why? So, okay, most of you are giving same answers. Yes, pseudo-orange is the case. Yes, you are right. It's a case of pseudo-orange. Yeah, but involvement will be of which structure? Which structure is being involved? Cooper's ligament. Yes, dear, the right answer is Cooper's ligament. Absolutely correct. The right answer is Cooper's ligament. The above image is of pseudo-orange sign. Pseudo-orange is an orange peel appearance of the breast caused by the involvement of suspensory ligament of the Cooper. So basically, the ligamentous support of the breast is gone, and it will cause the orange peel appearance. Yes, dear. Yes, dear. So this is the right answer. In breast cancer, the ligaments contract, become rigid, skin becomes puckers, and the ligaments shortens. So it's causing the dimpling, and the pseudo-orange sign is seen when there is lymphatic duct blockage also. But if I have to choose one, I will go with the tethering of the ligament, Cooper's ligament. If I have to choose one, I will go with the dimpling appearance due to the retraction done by the ligaments. Is it okay? Is it okay, everyone? Question number 26. A patient suffered from stroke. Previously has now presented with sudden onset of flaying from the ballistic movement. So this is from previous year question. What is the site? Hemiballistic movements. It's an easy one. Yes, Cooper's ligament is the right answer. Yes, previous one, Cooper's ligament is the right answer, dear. Yes, doc. Which is this is a direct MCQ. This is a direct MCQ, and this has been asked in the previous. Yes, Anush Chaudhary, is the subthalamic nucleus. Absolutely correct. It's the subthalamic nucleus. Again, a thumbs up goes for you. Yes, dear. So lesion of contralateral subthalamic nucleus of the basal ganglia results in the ballistic undesired movement of the limbs. So hemibalism is a stroke occurring in 0.5 cases, and the reason is the involvement of the part of subthalamic nucleus of the basal ganglia. So it's a direct MCQ. Now, Muscle attached to the arrow marked bone. So this is the second last question. So you have to identify the arrow marked area, whether it is which part of the femur, as you have to identify. And then you have to tell me that which muscle is attached on this structure. Iliopsoas, gluteus maximus, gluteus medius, or sartorius. So which structure is that? Which structure is that, my dear students? Iliopsoas is absolutely right, and this structure is lesser trochanter of femur. This structure is lesser trochanter of femur. Absolutely right. This structure is lesser trochanter of femur. Now, here you can see in this image, this is the lesser trochanter of femur which has been involved, and the marked structure is lesser trochanter of femur. And we know that iliacus and psoas major muscle coming from the lumbar region, but inserting together into the lesser trochanter of femur. So that is the right answer. Absolutely, a thumbs up goes for everybody. Absolutely correct answer, my dear students. Let's move on to the next. Yes, Sivani, I have marked. Yes, sir. Yes, you are right, Siva. Yes, we have already done that part. So iliacus is arising from, yes, dear, we have already done that. See here, yes, dear, the skin remains tethered by the ligament. Yeah, by the dimpled appearance. But if we have to go with the most correct answer, I will go with that of the Cooper's ligament here. Both are involved, but I will go with the Cooper's ligament here. Now, option B is wrong because gluteus maximus is inserting into gluteal tuberosity, medius from the lateral aspect of greater trochanter, and sartorius from the proximal aspect of the tibia below medial condyle. Okay, dear, let's move on to question number 28. This is a case of pseudo-orange. So that is by the Cooper's ligament. Okay. Is it okay? Can we move to the last MCQ, everyone? Can we move to the last MCQ? Which of the following marked structure represents merocrine gland? There is... So actually, this is a case of pseudo-orange sign, orange peel appearance. So, okay, coming to this last one. So this is for one of the students. So if we are talking about orange peel-like appearance of the breast, pseudo-orange sign, this is due to the ligaments. This is due to the ligament being involved, that is suspensory ligament of the, that is suspensory ligament, and that is Cooper's ligament here. So the ligaments contract, and because of that, skin puckered. Ligaments contract and the skin is puckered. So it leads to dimpling. So we will pick the Cooper's ligament as the right answer. It is correct that pseudo-orange sign is seen when the lymphatic ducts are blocked, but exactly that pithered appearance, that appearance which you are seeing is, which is shown in this image, is due to the involvement of the connective tissue support of the breast, that is the Cooper's ligament. Is it okay, dear? Is it okay, Sivani? Okay? Yes, yes, absolutely. B is merocrine gland. Actually, is it okay, Sivani? Now, B is merocrine gland, and I will tell you why. Actually, this is a case of the skin which is shown, and here hair follicles. Here we can clearly see this is the hair follicle. Okay, and this is the hair follicle. Okay, can you tell me what is A? What is A? Which, okay. So, just a minute, coming to this, actually students are asking of the previous one. Actually, most correct answers, we have to pick most correct answer. There is subdermal lymphatic drainage also. These two is not the right answer, and subdermal lymphatic drainage will cause swelling, discomfort. And if I am talking about the puckered appearance of the orange peel appearance, the most correct here will go with the Cooper's ligament. Okay. Lymphatic is not drainage, and the fluid will, if there is a blockage of lymphatic drainage, it will also cause swelling. It will also cause discomfort in the affected region. So the breast will appear a change in the shape. Discomfort is there. But if I have to go about the most correct answer among the option, will go with Cooper's ligament. Okay. Lymphatic edema also will be there with the lymphatic drainage. Subdermal lymphatic drainage is given, but not the blockage and all. So it is not exactly the correct word which is mentioned. So we will go with Cooper's ligament. Okay, okay, dear. Yes, yes, yes. Coming to the last one. Yes, dear. Yes, A is the absolutely correct. A here is the holocrine gland, and holocrine gland is the sebaceous gland. Yeah. B is the merocrine gland, the sweat glands. No. Dot, talk. They are not coming to this question. They are stuck on this one. I am not talking about the breast. I am talking about this appearance. This, in this MCQ, please don't get see the areola. My question is about this. My question is about this orange peel appearance. Okay. Here the MCQ is targeting about orange peel appearance. This one. Not asking about this. They are talking about the orange peel appearance. Okay. Orange peel appearance. And that is the pseudo orange appearance. So we will mark the Cooper's ligament as the right answer. Okay. Doc. Okay, the question is not about if I'm talking about the image, actually, we are talking about the image. The major area is showing the puckered appearance, the orange peel appearance or the pseudo orange appearance. So we'll mark this, not go towards the nipple and areola. The question is asking about this. Is it okay? Okay. Okay. Maybe the arrow should be marked on that area. Okay. Subdermal lymphatic drainage, but the word which is not given is blockage or anything. Okay, so that word is not given, and arrow should be marked here. Actually, if arrow, you got confused because of the whole image, but if we are talking about the pitted, like orange pitted appearance, so we have mentioned this connective tissue network and the Cooper's ligament. Okay. The pseudo-orange sign is the orange peel breast caused by suspensory ligament of the Coopers. Got it? Now here, where we were in the last MCQ, here in this case, we have got B as the merocrine, A as the holocrine, C is the hair follicle, C is the hair follicle, and D is the adipose tissue. D is the adipose tissue. Okay, dear? Now, okay. Actually, yeah. Got it? Again, I think I will again come to that MCQ because many of the students are still not satisfied. Let me tell you, if I am talking about the orange peel appearance, basically students, if we are talking about the pseudo orange appearance, why you are confused? I think because it is having multiple reasons. It is having multiple reasons. Okay. So the reasons will be, yes, lymphatic obstruction is absolutely the reason. Lymphatic obstruction is absolutely the reason, and also the Cooper's ligament is the reason. Lymphatic. So here the reason is showing subdermal lymphatic drainage. They have not used the word obstruction. This is to make you confused. If there was an option of A plus B, that would be more correct. But here they have not used the word obstruction. So we will go with Cooper's ligament. Is it okay? Then lymphatic obstruction is also showing, lymphatic obstruction is causing contraction of Cooper's ligament, and that is the reason of pseudo orange appearance. Okay, I think many of the students is repeatedly asking, they're confused for this. So I'm explaining once again. Lymphatic obstruction is the reason that is leading to the contraction of Cooper's ligament, and that is the reason of pseudo orange appearance. But here subdermal lymphatic drainage is reason. The obstruction word is not reason. Okay. The obstruction is not reason. So if we have to choose one for, if I feel that A should be gone. So that was confusing for you. But if I have to choose one, I will go with A. Okay. Now let's see the examples of merocrine, holocrine. Coming to this. Merocrine glands is the most common glands. No loss of cell membrane occurs, and it is seen in the parotid and salivary gland. Example of merocrine eccrine gland is parotid and salivary gland. If I am talking about apocrine gland, they are modified sweat glands and they are secreting the vesicles. A part of the membrane is lost, and such kind of gland is present in the axilla perineum. Sweat glands of the axilla perineum and ceruminous glands of ear. Holocrine gland, the whole of the entire cell membrane is lost and the new cells are secreted. Sebum lubrication happens by the drainage, and the best example of this is the sebaceous gland. So yes, we have done with this. Yes, before ending, Manisha is telling which topic to concentrate for the anatomy in the last 7 days. This topic. Okay. Okay. Before ending, I would like to tell which topic. So everyone, the topic like the transverse section of the cervical fascia of the neck, triangles of the neck, cranial nerves, the foramens, the cranial foramens. Also, you should know about the 3 germ layers and the derivatives, neural crest cells derivatives. You should be also practicing the sections of the abdomen and all the sections of the neck. You should be also knowing the nerve injury, brachial plexus, and the important nerves of upper limb and their injuries. That is very, very important topic. For lower limbs, the joints, the hip joint, the knee joints, and related clinical aspect associated with this. Head and neck, you should be thorough with tongue, thyroid, also with the necks, also with the neck region, the triangles of the neck. Also, you should, in the embryology part, you should be like omphalocele, gastrocysts, extrophy of the bladder, the 3 germ layer derivatives, neural crest cells derivatives, Teacher's Collins, first arch syndromes. All these things are very important. Histology part, all the examples of the epithelium. And I have shown also few images for the cartilage epithelium and the lymphatics, lymph node histology, the histology of lymph node, the histology of thymus gland. These are very important topics which you should not leave. Okay, for the abdomen, you should knowing the derivatives which is lying at the level of umbilicus, which I have completed in the session also. Is it okay? For the thorax, you should be knowing the topics of intercostal space. You should be knowing the contents of mediastinum, the sections of the mediastinum and the contents. You should be knowing the coronary artery circulations. So all these are important topics before the examination. Is it okay? These are the most important topics. Very, very important. So I hope the session was useful for you. So have you understood? Actually, I have tried to cover up the previous year questions, correlated topics also, histology part also. I wanted to complete a whole of the anatomy, but that would require more longer session. But these are the few topics which you should complete before the examination. It's very important. Actually, INI CET, what I have seen, like I have also given an image-based question of the cubital region, identification of the nerves, level of injury, what will be the presentation in the patient. That is all. That nerves is a very important topic and a favorite topic of INI CET exam. So be thorough with the upper limb nerves and their clinical features, the sign and symptoms, which will be asked with you. So it's very important that you should complete that topic. So please let me know, can I end this? Can I end the session now? Is it okay, everyone? We'll meet again with a new discussion. All the best. And I wish you all the best so that you are able to complete the session. Okay, dear? Okay? We'll meet in the next session. So go through all these MCQs, correlated topic, not the same MCQ will be asked, but correlated topic will be asked in the examination. Go through the most of the important topic, which I have explained already in this MCQ session. And I want you, like for example, femoral triangle contents and also adductor region is important. All the cadaveric images should be practiced. Thank you, all the best, and keep studying. Thank you so much. Thanks, dear. Thanks, dear.